Hello.
Hi, you all right?
Here is all right.
Yeah, yeah, yeah.
Right. We're very nervous.
Are you? Why?
I said, we're very nervous.
Don't be nervous. It'll be fine.
I should turn the volume up so we should be able to hear you better now.
Can you hear me all right?
Yeah, that's much better. Yeah.
That's good. Don't be nervous. They're all a friendly bunch. They're all right.
How many's in the room? Or will be in the room, do
Uh,
you know?
I don't know, but over 100, about 200, over 100. There's quite a
Right,
few.
thanks. Shouldn't have asked that
There's
question,
only
should I
three.
really?
There's only three
Did
people.
you say 10? Did you say
Yeah,
10? Oh,
10,
that's great.
One.
It's just
What's
us
that?
three, isn't there?
Yeah, yeah, honestly, believe me. What was that?
What are you doing?
I just dropped something on the floor that I needed to pick up.
How's Leeds? Is it sunny?
I didn't go into Leeds. It was all a bit hectic this morning, so I just thought,
Right.
rather than create mayhem, I'm just going to be in at work at home. It's a bit dark, isn't it, now?
Yeah, you look like you're in witness protection.
I'm not, I promise. So have you met the guys before? Have you done presentations for the carers lot before?
Never. Our virgin experience. I shouldn't say that. I was
Well,
drinking.
I'm not on the main carers team anymore. I got moved in the last structure, but previous to that, I worked on the carers team, and I did when we used to have the annual events. They were all face to face, so we used to run them with Steve. So I used to work with Steve and work with Jen Kenwood.
Right.
So
Okay.
yeah, and I'm a carer, and I used to be chair of the Carers Network for NHS England as well for 6 years. So
I don't know what you did then, but you're a lot brighter now.
yeah, so I don't know. I didn't do anything.
You should have said, "Oh, I did this, did that."
So yeah, so I know the team and I know the gang, so you don't need to be nervous at all. They're great, they're lovely. They're a good.
So is there 100 people at the conference, but they wouldn't
I
all be in
don't, I
this
don't know.
workshop, would they?
When the chair said something. Oh, there's over 100 now, but I wasn't looking at the numbers, to be honest. So I don't know what it is at now.
Well, forget the number.
So shall we practice? Shall I practice sharing my slides? So how are you going to
Yeah,
run
that
this
would be good.
session? What's going to happen? So you're going to do a bit of a brief introduction, are you?
So we've got, have you seen our presentation, the Encompass
Yeah.
presentation? That's a good start. Because in the first email, all it had was that woman's presentation that's on, there's another woman on in there before us, and she's on talking about her service.
Is she? Is the two of you? I've only got one.
So there's me and Sarah doing one presentation, and there's another lady from a different NHS trust doing another presentation before us.
I've only got one presentation for this morning.
Right. So what has the presentation you got Encompass written on it at the front?
I've got one. No.
No.
Right. Okay. So that's the other lady's presentation. So our presentation, I think, is a SharePoint link that was sent through on an email yesterday because it's too big to go on email.
Because we're the second part, aren't we?
I'll try and find the email.
Sorry, who are you? Brian, are you Laura and Ian?
We're Ian and Sarah from Encompass.
So I don't have your presentation then.
So I think you do. Well, I might be wrong, but there's an email sent out by yesterday by Brian Bennett.
To be honest, I've got about 50 emails.
It was one of the last ones, about 5:10. Maybe not that one.
No, I think it's just a bit further down here. I think there's something to do with somebody else is doing.
Right. So email sent at 2 minutes to 3 yesterday afternoon, and it's got a list of it's got your name and stuff, and it says Sharon, slides are too big to attach an email, but you can download them from here, and there's a link.
What was the title of the email?
Update email, commitment to carers, annual conference, carers identification and support pathways workshop.
257 yesterday.
258, yeah, 1458 it was
Yeah,
sent.
Sharon slides here, I've got them.
So then if you click on that link, that should open the Encompass presentation.
It opens the one. Let me show what I've got. Well, it opens more than a carer, but it's got your names on it. It doesn't. Oh, Ian. Let me show it.
If not, we could share it from here, I suppose. That would be the other way of doing it, wouldn't it? I'm not sure how that works. We could share our screen and put it up.
Just downloading, that's what I'm doing.
Is she the, yeah, she's the first speaker, isn't she?
Yeah, so Laura Greene's the first speaker, and then it's Ian Scott and Sarah Lynch.
So bear with me. Just let me go back and come back in here. This is the one that
Right. So that's the main one.
Yeah.
But then further down in that email, there's this bit that says Sharon, slides are too big to attach an email, but you can download from here. There's a SharePoint link.
yeah, that's what I clicked.
That's what it brings up.
And he brought that up, right?
Yeah.
Okay then.
Yeah, that's what I mean. It keeps gone down. There's only Sharon, slides are too big to attach an email. If I click that link, that's what it brings up.
And it brings up that, right? Okay then. So that's not our presentation.
Yeah,
So
that's
should we just
So
have
if
a
you-
go now, quickly, at sharing our screen and putting our presentation on?
If you
Actually
send me
tell-
the email, if you send me your
Oh, right.
email, put it in the chat or send me your presentation email. I'll share it now.
Right, but, okay then. Right, I'll try it. Okay.
Stop sharing. So who's going on first then? When's the other person coming?
So Laura Greene is presenting first.
Yeah.
I've not written anything on it. I've just not got a subject heading. I've just sent it. All right, attached.
Yeah, that's fine. It won't let me in. Wants a verification. It won't let me in. Won't let me access it.
Okay. So
Just present it in Teams, can you?
Do you know how to share? Or do you want to share? Do you want
I know how to. Sorry, I know how to share.
Mhm.
I'm just wondering if I can.
So was your presentation sent another way other than just email? Because I should have received it if it's
It was sent on Friday, but it's sent as a SharePoint link.
on Friday. What was the title of the email? I've got one on Friday from Steve, and it says, please find attached final version of slides for the up and coming carers identification. Is that the one?
Yeah.
Sorry.
So this one should be yours then, shouldn't it? Which comes up next.
Can't find it.
Laura Green channel.
Hi there.
Hi.
Hi, I'm a bit confused. I'm Laura. Hello. I'm not confused
Hiya.
about being Laura, but I'm
That's
confused
good.
about the timings of the workshop.
5 minutes.
5 minutes, so I
It's
can
in
go
5
back
minutes, yeah.
I can go back and listen to.
No, we need you in here.
Oh,
if
you
that's
do?
all right. Yeah, we want you in here because we need to get organised with what we're doing. So my name's Sharon. So I'm going to do the presentations. The link that you sent, that's the one I'm going to share at
Yeah.
the session. So how are you going to run the session? How's it going to? What's the format?
Well, I've been asked to speak for up to 20 minutes on carer identification and NHS carer pathways. So I've got that prepped.
Yeah.
That's as much as I know, Sharon. I don't know if I was supposed to contribute in a different way.
No.
You're happy with
So,
that?
so
Okay.
are you going? So you're going to open the session,
Yes.
and then you're going to do your 20 minutes,
Yes.
and then I'll share the slides as well. Is that what
When you
want me
say
to do?
open the session, what do you mean by that?
Just everybody's who's going to come to this session is going to, because I don't know who's kind of chairing the session.
Ooh, I don't know either. I've just been asked to give a presentation. I don't know the other speaker. Is it yourself, Ian? And
So me and Sarah, the other speakers. Is Brian attending this thing? I think Brian might be
Yeah.
chairing because Brian has to take something back to the main room at the end. That's what it says in
Right.
the
All right.
email.
Okay.
So my email, Sharon, on Friday was addressed conference more than a carer, delivering a fresh approach, presentation 24th of June.
Sorry, what it was? Sorry, who sent? Sorry, what was the night? What's the
So I
title of
sent-
the email? The email.
So the title of the email is Conference More Than a Carer, Delivering a Fresh Approach, presentation 24th of June 2025.
Can you
So
send that
many
to Sharon?
emails. Sorry.
Do you want me to send it again to you?
Yeah, please, if you would. I've just got so many emails now. It's just getting insane. I don't know where Brian is. I'm not sure.
Yeah.
No, just do that, Laura. I'll get your slides up. If you send me yours again, Brian. That email.
Is there any way of making the presentation a smaller file? Because it's 34 megabytes, so that's why it
So-
only sends as SharePoint.
My understanding is that Steve Mubarak sent the pack yesterday.
I've got it.
You've got it, right?
Yeah, but there's 2 different emails. There's 2
Oh,
different
right.
presentations
Sorry.
and they weren't sent together.
Oh, sorry.
It does say it on PowerPoint. Sorry about this, Laura, but we're having problems with ours. But it does say on PowerPoint, present in Teams. If we present in Teams and we're on a Teams call, will the presentation come up on the screen?
Should do. If you share your screen.
So should we just try that now and see if that works?
Yeah.
What's that?
That's presenting in Encompass Northwest. Cancel out. So that brings up that'll bring up all our notes.
Yeah, we want to see all that then, aren't they?
Can you see the presentation now?
Yes.
So you can see the first slide, but you can't see our notes.
Correct.
Yeah, so that email, Ian, I found it, but I can't access the link on it because it's blocked. I don't have access to your wherever it's saved.
Okay. So I think this is probably the best way to do it, isn't it? Then is to if we share our screen when it's our
Yeah.
time to, and then we sort of like run the slides from here and
Yeah.
read our notes that way around?
Is that all
Yeah.
right? Does that feel right for you guys?
I
Yeah,
think we're in the
that's
last
fine.
chance to lose. So I don't think we've got a choice, to be honest. Obviously, our nerves have gone up a bit high.
Don't
I
worry,
think my
honestly,
heart's
don't
going a
worry
bit
about.
faster.
Don't worry. This is what these little things always happen before. But once it starts, it'll be absolutely fine. Just don't panic. This is just normal. Don't worry. Doing all right. You've done your
Just
stuff. You
hoping
know
Laura-
your stuff. You've got your slides, so everything's good. Don't
hoping
panic.
Laura overruns and there's not much time for us. That's our
No,
Yeah,
plan.
take as long as you want.
No.
Right, so I'll stop sharing for now then.
Okay.
But you
And
didn't
Sharon-
see our notes or anything?
No,
You-
just
no,
the
no.
presentation.
Right.
So if you let me know, I've got that link. Let me just double check that it's the right thing with you. Bear with me, and then I'll share. Oh,
Yeah, that
not
looks
used to
right.
it. Is that all right?
Looks right. If you just tab a few slides and let's see if the presentation comes up. So that's the housekeeping that Brian will do. Yeah, that's good
Is
for
that
me.
all right?
Yeah, perfect.
Turn speaker coach. Don't need to do anything else. Brilliant. And then I'll just unshare. So just let me know when you want me to, if you could give me a second just to, because it takes a second to upload. So give me a second warning of when you want me to upload the, and well, start sharing, and then I couldn't do that.
Okay.
To unshare.
Laura, are you doing questions and answers? Questions, answers, and I don't know. You know what I'm trying to say? Q&A. Are you doing it after your presentation, or are
No,
you doing
no,
it
I
right at
think,
the end?
well, this is the kind of thing that I thought Brian might decide on.
Yeah.
I
Where is Brian? We
personally,
need Brian.
personally think it's best to do both presentations and then take questions. Otherwise, it eats into your time.
That would be a shame.
It would.
Oops, something else is here. Somebody's changed that background to something else.
Hi, Amy.
Hello. Just trying to get my camera on. There we go.
Oh, we've had all our
Hi.
tech glitches before you came.
Yeah, it's just that it's my mouse for me. My mouse keeps double clicking, so I keep turning my camera on, and then it immediately turns it
You're
straight
going
back off
places.
again.
You end up in places you don't want to be.
Yeah, so I definitely need to go in and change my mouse, but it's fine. We'll work through it. It's all good.
Good. You managed to get here, so you're all right.
Yeah. I find perseverance and generally just jabbing it works eventually. So
It'll give in to you, won't it, if you keep doing that?
yeah, you just cower it into sort of, conformity.
Hi everyone, I hope you're enjoying the sessions. Some good conversations.
Yeah, thank you.
Just give it a few minutes for everyone to arrive and wait for Brian. Just give it another minute. Let everyone settle in. I'm sure a few have run for a quick coffee and a quick toilet break as well.
Hi everyone. We'll just give it a couple of minutes because I think a few people have just gone for a quick comfort break. So we'll kick off around 11:34 to be precise. So I'm just double checking we've got our speakers. I can see Laura. Hi Laura. And have we got Sharon? Got Sharon, tech support, and Ian and Sarah. Yeah, Ian, I can see you. Perfect. Right, so we'll get going. I think people may join us as we go because the 5-minute break was not entirely sure when it started. So hi everyone, I'm Brian Bennett and I am a senior program manager in the Northwest regional team of NHS England, and one of the areas that I have sort of some oversight of is unpaid carers, those community services and experience of care. Really pleased to be kind of facilitating today's session. We've got Sharon, Griffin from the national team as well, who's providing all our tech support. Have you got the slides there, Sharon? Because I've got
I have,
to do
yes.
a
Do
bit
you want me to start sharing them?
Yeah, if you put them up now, because I have to do the usual bit of housekeeping, and then I'll be quiet because it's more important to hear our speakers today. Hopefully that's all worked. Oh, you were there. So if you just snipped, yeah, so quick housekeeping, the usual stuff. Hi everybody, really pleased that you've joined the workshop today. I'm hoping it's going to be an interactive session. So the way we've split it is that we've got the two presenters and then an opportunity for some question and answers afterwards. But I'm quite happy if the presenters are as well. If there's a burning question that you've got at midway, please put your hand up because we want it to be interactive, because otherwise we're sitting around listening and not talking all day. But yeah, if you could keep microphones on mute and all the usual stuff. They are being recorded, so if you prefer not to be on screen, then just pop your cameras off. And I think that's about it. Want to flick to the next one? So yeah, so Dave's asked us to be back by 12:20, so we've got slightly less time than planned, but we should be fine. because I won't be doing 5 minutes introduction. Obviously, it's a really, really important area. It's probably one of the key areas, isn't it? It's quite hard to talk for 45 minutes on carer identification and support pathways, but we're going to hear about two really good examples today of some great work that's going on that hopefully we can build on, like we're talking about today. There's definitely this kind of trying to have a positive outlook today and really be inspired, and hopefully the models we talk about today and the discussions will do that. So I will hand over to Laura and Scott. And yeah, please introduce yourselves and we'll get going. Oh yeah, by the way, before we finish, at the end, I need to, as a group, we need to identify one key point we want to feed back to the main group. So please have that in mind during the session, and I'll maybe pull up a few options at the end and we can have a democratic process. Right, I'll stop talking now. Laura, over to you.
All right, thank you very much. My name is Laura Greene, and I have two roles at Kingston and Richmond NHS Foundation Trust, which is a lovely acute and community provider in South West London. So I'm the lead for unpaid carers, and I'll just say a little about how that came about. And in my day job, I'm head of volunteering and community partnerships, but it's a pleasure to hold both briefs. And I'm talking today about carer identification and NHS pathways. So the service that I have set up over the last 3 to 4 years is called the Carers Clinical Liaison Service, and I just want to go a little into how that service was established for, firstly, the acute provider, Kingston Hospital, and now that we've merged with a community provider, it's now a pathway across acute and community for unpaid carers. So the reason I became lead for unpaid carers was actually as a volunteer. So as everyone on this call will know, the Health and Care Act, Section 19 was amended in 2022 and put a duty of care on acute providers to involve carers in hospital discharge. And my trust asked for volunteers across senior leadership to design how our trust would respond to that duty of care to unpaid carers and bring to life their involvement in discharge decision making. And so from the outset, we knew that the KPI, the measurable of this service or intervention, whatever it was going to be, was around measuring carer experience of hospital discharge. And as we all know, measuring something as kind of intangible as experience can be really difficult to quantify, but I do think we're there, and I'm going to share some data today. I think what was important from its outset was that the service had multiple funders. So we had funding from the ICB, we had funding from our local authority, and we also had funding from the hospital charity. So really from the outset, the kind of the task and duty of identifying carers was seen as a system-wide responsibility. It wasn't just one hospital's job to do all the identification. It really was a three-way relationship between the ICB, the local authority, and the acute provider. First year was a whirlwind. We identified just in the hospital setting over 2,400 carers in our first year. But I would say that in the 3 years of being active as a service, that's now settled at identification of approximately 1,000 carers. And that's not to say that we've slowed down. It's more about recognising that once you've done the identification piece, the carers need a really robust pathway of support. And it's not just stopping at the point of identification, which looks great for your statistics. It really is about providing robust and thorough support so that those carers actually have a clear offer, and also safe transitions between the hospital and wherever their onwards destination of care is for their cared for person. We're now TRIO funded, just 2 local authorities, and the trust now provides a substantive contribution. But of course, funding is time limited. So we are still with our begging bowl, even though we are now recognised as a substantive core service within the trust. The money simply isn't there to sustain it. So that's kind of an ongoing challenge for myself. And what's really lovely is, as I said earlier, as a trust, we merged from being an acute provider into a acute and community provider. And that's really exciting for our work with unpaid carers, because it means there's a no wrong doors approach. So within South West London, within our patch, wherever that carer is presenting and therefore identified, it shouldn't matter where their cared for person is receiving their healthcare, whether that's a local clinic or right through to a ward on the acute hospital, they're getting the same pathway, which we felt was really important for parity of experience, regardless of whether that unpaid carer is coming to notice. So next slide is how we identify the carers. So within our service, of those 1,000, 750 will be clinician-led. And we do a big piece of work around education of clinical staff to ensure that that education is happening at the front line. We don't want to be a second line of defence. We really need all of our clinicians to be carer aware, whether they're a doctor or a band 2 healthcare assistant. Everybody needs that responsibility, that duty of care to recognise when an unpaid carer is struggling or lacks information or could benefit from some information that will enhance the support that they're receiving. 25% would be practitioner led. So we have 2 band 5 carer practitioners, and whenever our referrals are at 75%, they're going into patient notes, they're going to RAG meetings, and they are proactively screening the patient cohort that is across our trust at any one time, looking for signs and signals that there is an unpaid carer involved in that decision-making process. And that's how they make it onto our list. We also have, if you could go back, I haven't quite finished that slide. We also have, as a service, insight into other digital referral lists. So I'm sure you're familiar with electronic patient record systems. So now they're wizzy enough to be able to automate referrals. So we have kind of our big referrers. So, for example, the dementia and delirium team in the hospital, the learning and disability team, we're constantly screening their lists, because the likelihood is if somebody is in the hospital with a presentation of dementia and delirium, we're proactively looking to see if there's a carer involved in that person's healthcare and whether they're eligible and in need of our support. From an education perspective, I said earlier, education is key, because our service is nothing without referrals from the clinicians at the front line. So we have a trio approach to education. We have a Think Carer campaign, which you can see in the yellow box on the right. And that is a scheme whereby every member of staff in the trust is encouraged to make a pledge. The pledge is a recognition that they have read some information that makes them carer aware. Primarily, it's the rights of the carer and the pathway that we have here at Kingston and Richmond. They have a corresponding lanyard badge, which tells the public and the patients that they are carer aware. And we also regularly flush the hospital with some bright yellow A5 referral cards that we leave on computers. We leave with senior nurses to distribute to their teams through meetings, through RAG meetings, through their Big 4 huddles. So we are flushing the hospital with our yellow awareness campaign. And then we also are embedded as a service in some key education platforms. So we are training band 5 and band 6 nurses in their induction programs. So all new nurses into the trust receive carer awareness and identification training. And we also, because we live in quite an affluent selection of boroughs in Kingston and Richmond, there is a heavy presentation of frail elderly individuals into our hospital. I'm just going to stop my computer from restarting. That would not be great. So yes, we're also present on a South West London-wide older persons nursing study day. So really getting the message out through our nursing colleagues that they are the front line of identification for unpaid carers. We also, as a service, do lots of roadshows around the trust. Big participation in things like National Carers Week to make that awareness stick. And we are on our own waiting list for to become a service whereby clinicians can make a digital referral. At the moment, it is manual, so they have to send an email or bleep us or pick up the phone. Within the next 6 weeks, that will be automated. So again, we expect to see a spike in referral because that identification piece will become so much more efficient for the frontline staff. Okay, now we can go to the next slide. This may well be familiar to you because we have taken our carer pathway, borrowed very heavily with kind permission of Sharon Harris and Debbie Hustings from the NHS England London Hospital Carers Discharge Toolkit. So this pathway is the promise that we make to all of our unpaid carers as to the 5 pillars of support that they will receive. And On the next slide, I've got a summary of how that's communicated. But if we just stay on this for a moment, I'll just pause on each one briefly. So the identification piece I've talked about at length. It's also about asking, even though we do have a lot of care of the elderly patients, and thus the average age of our carer is actually 64 years old, we do ask every unpaid carer whether there are any children or young people involved in their care. And we also have a very good relationship with our paediatric department, looking out for referrals for parent carers. The welcome and recognition stage is around the carer knowing that they have a place in the triangle of care, and that welcome is made by any member of staff, regardless of who it is doing their clerking or welcoming them into the organisation, and they are given a referral into the Carers Clinical Liaison Service. So that's their welcome and recognition. By way of assessment and support, that is the bulk of the work that my service does. So the carer goes through an assessment process that we've taken from a number of evidence-based carer assessments and kind of synergize them to create a bespoke one for our trust. And we will then initiate that support plan, whether that is things like clinical liaison. So if the carer wants advocacy at best interest meetings, at mental capacity assessments, we will be there advocating for the needs of the carer. Or it might be information provision, it could be advice, depending on where the crisis is for the carer, and really just asking questions about how they feel they are coping right now, how the medical presentation has changed their caring responsibilities, and how they feel they're going to cope when they get back into the community. The involvement of the carer is key, and we are educating constantly clinical teams, MDTs, around the triangle of care, and ensuring that the care is given equal weight in decision making. And then the transition piece is around ensuring that that voice is heard through discharge planning, and that the carer's resilience is considered and accounted for by way of the support and the package of care that that patient will receive, that the carer's needs are also identified and recognised in that decision-making process. Okay, next slide, please. So this is what the carer actually receives. This is a lanyard that is given out to every carer, and you can just see there two sides of the coin. The first side is their rights in hospital, so that they are aware of their entitlements whilst they're with us, and then the pathway that I've just described, so that they can, if they feel they're not, for example, receiving the right assessment of their needs, they can advocate and they can say, hey, this is what you've set out as the global expectation, and I need more support to get my needs recognised. So a little bit now, if we move on the results of the service. So we've been going about 3.5 years now, and as I said at the outset, we knew that we wanted to meet that duty of care to involve carers in hospital decision making, particularly around carer discharge. So we did set up a mechanism to measure that. So at the outset of the referral, we will ask the carer how they're feeling about their involvement, their level of involvement in care, in treatments, decision making and discharge, and they will rate it out of 10, their level of involvement. And then when we close the case, we ask the same question, and we're really pleased to see that the intervention of the service is seeing up to a 50% change in carers' feeling of their involvement in discharge decision making specifically. And then we've done a piece of work with our business intelligence team, looking at, if a carer receives support, what's the impact on their resilience, but also what's the impact on the cared for person. And we were quite surprised actually to learn that with the support of the Carers Clinical Liaison Service, the cared for person is 13% less likely than their control group to be readmitted to hospital. So what this data is showing is that if we as an acute sector prioritise carer resilience, pay attention to carer needs, and proactively plan for what those needs, how those needs are going to be met in the discharge decision, the cared for person is less likely to deteriorate when they go home from hospital. So we were really pleased with those results, but I think it's that's data that the minister needs to hear, because it proves the concept of carer support. Last couple of slides. The service would be nothing without the partnerships that we have in place to enable that safe transition of care for the unpaid carer. So within the trust, we have a number of internal partnerships, some of which I've mentioned. So, for example, we do a lot of clinical liaison with other teams, for example, the palliative care team or the dementia and delirium team. We have a very close working relationship with our transfer of care hub, which is where decision making is completed around discharge. And we also collaborate to ensure that where there is a contingency plan on the, on the updated urgent care plan, that is read at the front entrance, and contingency plans are acted upon admission of the person with the caring responsibility. We also have created a discharge summary scheme. So once that case is closed, with the consent of the carer, we will create a discharge summary, and that can go to a range of stakeholders. For example, the GP of the carer, it can go to their employer, it can go, if they're a young person, to their school or education liaison officer, and it can also go as part of our referral to local carer centres. So the idea of that final pillar of transition is that we leave no stone unturned to ensure that the work we've done to support that carer and articulate those needs in the acute side are communicated into community providers, and hopefully they will then be taken forwards and brought to fruition. And then we also have a partnership with our local South West London Accelerated Reform Fund kind of network. And one really good thing that's come out of that funding is we've established a South West London hospital, that's a bit of a mouthful, hospital carers professional network. And we've really committed as a collective of hospitals to sharing that carer pathway, to really expand that principle that there's no wrong door, that regardless of whether that care is receiving, come to notice at Croydon Hospital, at Epsom St Helier, or at Kingston Hospital, St George's, those pillars will be guaranteed regardless of where they or their loved one are receiving that care. So I think that's my final slide. Just one more, if I may. The other thing is with regard to partnerships is hyper-local partnerships. So you can see Dr. Neil Churchill there came to something that we call a one-stop shop. And that's something that as a hospital we do in partnership with our local voluntary sector carer centres and our local primary care network of GPs. And that just ensures that everything that we do in the hospital is it's sent out into the community. And so rather than waiting for the admission, waiting for that point of health crisis, we are proactive in the community, bringing together lots of different groups, organisations, people that help and support unpaid carers, so that it's not always at crisis that you're receiving the information where you can't necessarily process it. You can't make there's such a density of information at that point. We are proactive in ensuring that people know that when they come to Kingston Richmond Hospital or the community provider, they are in safe hands. So that's a summary of our work, and thank you very much for your time.
Great, thanks, Laura. Just in the interest of time, I was thinking if people have got any specific questions for Laura, if you put them into the chat if you're able, while you remember them, and then we'll come to them all at the end, if that's okay, just so we can get moving on with Ian and Sarah. So Ian and Sarah, over to you.
Okay, can you hear us okay?
Yeah, all good.
Okay, great. We had a bit of a panic at the beginning. We thought our presentation wasn't there. We're going to have to sort of send it over, but it looks like it is going to follow on from this one. That's really good. So, so welcome to our presentation. It's about the Wellbeing and Early Support Service and how we've sort of been seconded into this role through the Carers Project. So my name's Ian Scott. I'm an Assessment and Support Officer. I've worked for Encompass for 9 years, and I'm currently on secondment with West Central for the next 12 months.
Hi, and I'm Sarah Lynch. I'm also an Assessment and Support Officer. I have also been working for Encompass for, it'll be 10 years this September, and I'm also on secondment for the next 12 months with the West team. So just a little bit sort of about us really. So Encompass, so we operate in the north of England, and we are the largest provider of carer services in the north of England. And sort of some facts and sort of figures. So the period of 2023-2024, we supported and delivered positive outcomes for over 40,000 people. We're a staff team of 161 passionate people. And as you will be able to sort of see, we sort of started in Lancashire, and our sort of footprint has sort of spread across the fields, further afield, and we provide carers, advocacy, wellbeing, counselling and volunteer services. And we are sort of our advocate, our sort of say is that we are people, we put people at the centre of everything that we do and deliver excellence by utilising people's strengths to stay well.
Next slide. Thanks.
The actual Lancashire Carers Service, so the department that we work sort of within under Encompass. So at Lancashire Carers Service, we adopt a person-centred approach to the delivery of the provision of the field of identifying, supporting and empowering previously hidden carers of all ages from 18 and above. We do also sort of have inquiries about sort of young carers, so anyone that's over the age under the age of 18, we will signpost those to Barnardo's. And every carer we sort of have contact with, we are sort of privileged to sort of join them on their sort of caring journey, listening to their story and supporting sort of as appropriate, really. And each carer, you know, that we sort of have contact with are caring for a loved one, a friend, a neighbour, that either have sort of physical health issues or have mental health challenges. And these also include sort of those individuals that have attempted to sort of take their own lives as well. We engage with a variety of carers who speak many languages, and we would seek the resources of Language Line to connect these carers with their own language. And we also do support a number of carers that have other sort of forms of communication difficulties, like sort of deaf carers. And again, we would use sort of BSL interpreters so we could connect with these carers. Lancashire Carers Service, we provide specialist support for carers to improve their health and wellbeing and enable them to continue in their role for as long as they choose to do so. We offer a blended approach of face-to-face support and a digital online offer to ensure carers always get the support of their choice. And again, just some sort of facts and figures taken from 2023 to 2024 is that we have 53,325 registered carers. 8,621 new carers identified in the year of 2023-2024. And then we also provide a 24/7 online carers community network, offering peer support to all our carers.
Okay, so over to me now. So the Lancashire Carers Service is delivered by two organisations, Encompass and Carers Link. You're probably wondering what WES is, but WES is the Wellbeing and Early Support Service run by Lancashire County Council Adult Social Care. The WES service work with new service users who have not been supported by adult social care in the past. Referrals come from a variety of sources, including the police, ambulance service, GP, health professionals, and self-referrals. The WES team aims to address short-term social care support needs and to minimise the need for further social care interaction. They also aim to be proactive in preventing potential hospital admissions and keep people safe and well in their own homes. The purpose of this collaboration is to identify carers at an early stage and provide a carers assessment or connection with carers services to access support or signposting to maintain the caring role and reduce the demands on social care. We were provided with an opportunity to secure 12 months secondment opportunities based within and working alongside WES East, North and Central. These secondments commenced this year in April, so we're in the early stages of this work. Next slide, please. The accelerated reform and funding is what's funding the project. The ARF is a 42.6 million grant programme established by the Department of Health and Social Care to support innovation and capacity building in adult social care over the years of 2023 to 2025. The ARF, it's hard to say, the ARF is designed to promote partnership working across local areas, as well as sharing learning and best practice through conferences such as this one. The aim of the grant is to kickstart developments of projects that can be further supported through existing local authority funding. The Lancashire Carers Service was successful in securing funding relating to Priority 12. ways to encourage people to recognise themselves as carers and to promote access to carer services. We are well placed, being seconded within the WES team to support with early care identification and offering early support and prevention. The ARF funding is being used in part to backfill our existing roles with Lancashire Carers Service, so this service is not affected by the secondment.
Next
slide, please.
This is sort of my favourite slide, identifying sort of carers, and I sort of actually chose this picture because I do feel that our carers feel that they need to hide behind obviously the person that they're caring for because they feel that they're the priority. So for us it is about obviously just taking over into the WES role what we already do within our Lancashire sort of carers role. And just obviously we're in early days with the WES secondment, but what we're attempting to do and what we have done so far is just to be involved in case discussions, and obviously with the workers that have been allocated, the individual that has the needs, we will sort of either meet with them face to face or via Teams or via emails and have some discussions over those cases where they feel that they've identified carers. We've also had the opportunity to sort of join those workers and shadow on visits where again we've actually sort of asked those questions about whether they have anybody that does care for them and able to sort of pick the carers up from there. I also joined the daily huddles every morning at 9:30, where again I've joined the team and we all sort of discuss our cases, and again I'm able to sort of ask those questions about whether there are any hidden carers or if they've thought about carers in each of those visits or contacts with the individuals that the WES workers are working for. And again, our sort of main focus is about just being present and really just sort of keeping the carers in the spotlight.
Okay, next slide, please. So how's it going? Well, I was quite fortunate that when I started my WES role, that the team that I work for Central WES team, were undergoing a bit of sort of, there was new staff and there was established staff. So the managers had put in place a wellbeing day where they were all able to come together and get to know each other a little bit more. So they invited me along to that day. So that really helped in them getting to know me and vice versa. We've also, as Sarah's mentioned, been on home visits with the team and identifying carers and also sharing our knowledge at those home visits. And then we're working in their offices essentially. So I'm based in Chorley in Lancashire and I'm in their office twice a week. So they can't really forget me. And the idea being that when they're having their general discussions, such as the other week, there was a discussion in the office about getting reliable tradespeople to this person's house. And one of the established members of staff going, oh, no, there's nothing in place for that in Lancashire. And I was like, there is. But they weren't hearing me. So in the end, I just emailed straight across the office to the social worker. And she's like, I knew there'd be something in place. So it's just things like that, opportunities like that, where we're able to interject into conversations and sort of share our knowledge. And also, like Sarah says, mention the carers. So a good example was I went to my first team meeting for the WES Central and I was introduced to all the team. And a particular person was a social worker and he'd dealt with a case that I'd been working on prior to my WES secondment, and respite had been put in place for a carer. The respite was due to come to an end and the carer had been in touch just before I'd gone to the meeting to say that her mother had been unwell and had to stay in the respite facility for longer because the paramedics felt that she was better cared for in the sense of staying in the residential home and going into hospital. So the daughter was then concerned who was going to pay for the extension of the respite support. So I just went over to the social worker in the office after the meeting, explained the situation. And he said, oh, well, I'm not dealing with that now. It's been allocated. It's been like I'm unallocated because I've done my bit. I said, oh, who else do I speak to then? He said, oh, speak to the manager. So I just moved along the desk to the next person, spoke to the manager, explained the situation. She asked who was allocated. I said it was him. She gave the case back to him. The respite was extended. And then I was able to contact the carer and explain there was no need to worry about the additional extra days in the respite facilities. So something as simple as that made a big difference. And if that had been without the secondment in place, it'd have been emails, phone calls, and a lot of waiting around and anxiety really for the carer. Never mind everybody else sort of involved in that sort of support. And then another good example is Lancashire County Council on their intranet have an opportunity for staff to shout out and say when someone's done well or done good, so they can praise each other or praise other people, I should say. So it was quite nice to see that a shout out was made for me for sharing knowledge and advice on a particular assessment that I'd gone on, and that the social worker took the time to give a shout out for me on the system. So that was quite good as well. So we're obviously being heard and are settling in quite well. Next slide, please. There has been challenges, of course. So RAG rating. Now, on that previous presentation, I might be telling you this already, but you obviously might already know about RAG rating, but we'd never really heard of RAG rating until we got to our West offices. And RAG rating can make a big difference as to when the case gets picked up. For those that don't know, RAG, R is for red, meaning the situation is urgent, and cases where someone might be at serious risk. If they're experiencing domestic abuse, they have known to care for them, they're in immediate danger due to self-neglect or health issues. So these cases must be prioritised and picked up as soon as possible. Then there's amber for situations that are concerning but not immediately life-threatening. These might include people living in poor conditions, a carer who's struggling but has backup, or someone who is isolated and at risk of falling through the cracks. And then finally, there's green. These are the low-risk situations that might have planned reviews, minor changes to care plans, or people who already have a stable living arrangements. So having that RAG rating can make a big difference as to when the case is picked up. We also felt we've been kind of parachuted into established teams. So again, it was just a question of getting to know people and feeling confident, I guess, around those members of staff. Because you're kind of in an office full of social workers and social care support officers. So you just, you have to be able to sort of speak up and sort of get your point across, which can, I wouldn't say it's intimidating, but can be a bit sort of scary at the beginning. Other challenges we've faced was around sort of sharing information. What can we see? What can they see? As it happens, our Lancashire Carers assessments are already put onto the Lancashire County Council Liquid Logic system. So therefore, we're already inputting our carers assessments on the same system as the social workers. So that's like one good place, because then we're familiar with their systems and they're familiar with ours. There's been a few issues around sort of keeping involved and keeping our input with them on teams, just for different systems. But we've managed to work around it and find out different ways so we can still sort of connect with each other. We also created a carers tracker, so the West team can see where their referral's gone, you can see where it's up to, and they can see what outcome has come from that referral. And I think that might also encourage other members of staff to put more referrals in. The social workers and the social care support officers can enter their own cases onto that tracker, or they can send me the last numbers through, and I can do that. Okay, so we were asked to sort of next slide, please. We're asked to give a case study. So like I said, we are kind of new to the service, and we already sort of like hit the ground running in the last sort of month or so. So I sort of share you Janet and David's case. I'll sort of just explain to it. So initially, I met Janet and David well before the WES secondment role was created. It was back in August 24. David was a HGV driver and Janet was a retail assistant, and they lived together in Preston, and they were both in full-time employment. David was assaulted on his way home from work at a cash point and sustained an acquired brain injury to his frontal lobe. This affected his speech, his eating, his mobility, ability to drive, and confidence of being at home and in the community, bringing his working life and his home life to a halt. After discharge from hospital, they were referred to the West team for support. Initially rated as green in the RAG rating, as Janet and David had good family support. David could be left for most of the day, and they were seen to be managing okay. Janet was referred to the Lancashire Carers Service, and this is where I sort of picked up the case. I undertook a carers assessment with Janet in August 24, and working through the carers assessment, I was able to share information and signpost it to local services. The carers assessment progressed through the steps 1, 2, and 3. And initially, David and Janet didn't want any involvement from care agencies, as they had informal support and they felt that was working okay. One of the outcomes, when the assessment process had finished in October, they agreed to a referral to social care for respite support and, if eligible, a package of care for David through direct payments, because he was willing to take on support from another person but didn't want a group of carers coming in and out every day. So this referral was made by myself into adult social care. And I kept checking back with the carer, but unfortunately there'd been no contact with from social services with the carer, I would imagine, due to their backlogs for referrals. After a discussion with Janet in January 2025, I contacted adult social care to follow up the referral, and it had been sent to the WES team, and I encouraged Janet to do the same. By March 2025, someone from the WES service contacted Janet and they discussed what support was in place and what they were looking for, but the case was still rated as green under the RAG system. I contacted Janet for an update in April, and David had been admitted to hospital several times due to his health deteriorating. By May 25, I was now in place in the WES team, and this case was sort of burning at my heartstrings to get involved and sort of to find out what was happening and get some support in for them. So I was able to speak to the manager face to face and put across Janet and David's situation. Following on from this discussion, David's case was recategorised to amber and the social worker was allocated to the case. And I felt by having that opportunity to speak to the manager, that pushed that case much further along than if we hadn't been in that WES role. In June, I was able to join the social worker on a home visit to meet David and Janet. And this is the first time I met them because all my previous work had been done over the phone. They referred to me as the man on the phone. So Janet had recently been on unpaid leave supporting David as he needed round-the-clock support due to deterioration in his health. Whilst on the home visit, I was able to encourage David and Janet to look at what other support was in offer in order to maintain Janet's caring role. And the following outcomes were achieved. Next slide, please. David has come to accept that he will need paid carers calling in on him when Janet goes back to work. They're changing the way they live at home to accommodate David's health needs. And the social worker is still involved in putting a package of care together so Janet can return to work and David can be cared for while she's at work. I continue to support Janet with the information and support every time she faces a new challenge, and Janet's case will be reviewed in August by the service. In the meantime, Janet can return for any support she requires.
Next slide, please. Thanks, Ian, for that case study. Yeah, so really just to sort of sum up, obviously we are really early into this secondment and still sort of finding our feet, trying to obviously spread the word, still obviously advocating for carers and learning obviously within the WES team as well. But sort of our future sort of aims is that hopefully after the 12 months we will have a lot of positive outcomes, and that will lead us hopefully to be able to hot desk in the WES office to obviously keep our presence alive and you know the word for carers out there. We will hopefully improve and keep ongoing partnership work with key partners and stakeholders, that there will be continued early carer identification and therefore continued valuable early intervention work, which we just hope will just strengthen sort of everyone's sort of health and well-being to get the best outcome for our carers. We will have a model of excellence for any future sort of similar project opportunities which have already been troubleshooted and streamlined, and we will have evidence of meaningful and effective outcomes to support business sort of case for ongoing funding for the future. Next slide, please. And that's sort of our presentation. I'm glad you sort of bared with us. It was the first time that we've ever presented sort of in this manner. Obviously, thank you for listening, and I think obviously it's open for any questions for myself, Ian and Laura. Thank you.
That was fantastic. Thank you both. Really interesting to hear. Particularly, it's nice hearing when you're just starting off the new service. And now we've only got about 5 minutes. One of the benefits, I suppose, of this has been the amount of networking that's going on in the chat, which is fantastic because there's been some very big questions and suggestions made in there, and people are linking up. So we're not by any chance going to be able to cover, a tiny proportion of that in this moment, but do continue what you have been doing, is linking up, and Laura's volunteered to be contacted, I'm sure. Ian and Sarah might have been contacted as well. One of the things I just wanted to flag is you've just finished your presentation there, Sarah, with it. It's around proving the impact. Now, we've just heard two really impressive models, but they're all based on short-term funding, and that's the problem with just this ongoing issue, isn't it? We know what works in many cases. We've seen so many examples over the years of what works, but it's all based on this short-term funding. So I suppose my challenge, I don't know if people agree, my challenge to the main group is, right, how do we stop this short-term funding cycle and make this built into the commissioning model for services? Because I think you said, Laura, didn't you, in terms of the impact that your service has, it makes it a more efficient and productive service overall. You've got less admissions, for example, and that's the thing that makes people tick, doesn't it? If the finance manager is happy, then everybody else is happy. So just quickly, Laura and Ian and Sarah, in terms of that sort of proving a worth, how have you kind of gone about that, Laura? Well, you're sort of, someone asked about your evaluation. Could you sort of sum up in, I don't know, 80 seconds, 90 seconds, what you've done to try and prove that kind of the model and try and get that future funding?
Yeah, of course. So, quarterly reporting on kind of performance KPIs, but the two KPIs that really matter are the change in levels of involvement. So we ask that question before and after out of 10, how involved have you felt in decision making? And we've seen a 50% change. So going from, let's say, a 2 at the outset of the relationship to a 7. And we mark that as a 50% improvement because it's a 10-point scale. But the 13% reduction in admissions, we looked at 1,000 unpaid carers and their patients, and we looked at a sample of the same age and demographic of patient. So we had a control group, and I looked at 2 factors: length of stay and readmission within 6 weeks. And I was able to calculate from the general sample what the average rate of return was within 6 weeks, and then look at our cohort specifically of 1,000 carers and what their return was. And I think it was something like, it was in the 20s, about 25% average within 6 weeks, and 13% less for the patients whose carers had support. So it's not perfect. It is a bit rough and ready, and I did have the support of a business intelligence team, but it was really just a sample, a control group, and compare and contrast the same KPI.
That's brilliant. Yeah, I'm sure others be interested in that. And Ian and Sarah, what are you having to do? Is it just kind of making a case and putting the examples like that case study forward, that kind of thing?
Yeah, I think essentially we'll just be gathering good examples of people that we interact with in cases, and just hopefully, showing how that's improved their lives.
Yeah, it's just that ongoing challenge. And I think Linda's just made a good point there. It's everywhere's under pressure, aren't they? Everywhere's under financial pressure. So that's the first things to go is things like this often, because people aren't being hit over the head about it. But it's aligning the impact that you're having on those kind of key areas that are very important to government, important to sort of finance managers, showing the impact it has on those, I think is key. So if people are in agreement, not that you've got much chance to disagree, I think my kind of key point is around this, the importance of making this sort of, building this into our commissioning, stopping the short-termism for these kind of services. Because Dave said, didn't he, it is literally a postcode lottery, isn't it, in terms of what's available to people. And that's the thing that we need to start addressing. So if people are happy, that is going to be my key point. But there's been loads of brilliant points, and like I say, there's loads of really great stuff in the chat, so we'll keep hold of that and do carry on sort of linking in and networking with each other. If anything you want to flag, do get in touch with the national colleagues. You've got all the contact details, and we can sort of facilitate discussions from here. So thanks very much. Hannah, did you want to come in, or are you just putting your hand up? Oh, no, sorry. Right, thanks very much. I think we're going back to the main meeting now, and enjoy the rest of the day. See you soon.
Thank you.
Cheers.